Good evening, madam.
Good evening, and good morning, and good evening to everyone.
Good evening, everyone. Raman sir, Dr. Graham.
Good morning. Well,
Good morning.
it's morning here anyway.
Shall we start?
Yes, sir.
Good evening, everyone. Thank you for joining on a Saturday evening. It's raining here. It's monsoon time. So every year on this day of World Sickle Cell Day gives us an opportunity to remember those afflicted by this disorder of hemoglobin synthesis, to discuss and reflect on how their care and management can be improved with a focus on equity. We at JSS became involved with sickle cell disease in a tangential way. It was while investigating and reviewing maternal deaths in eastern Madhya Pradesh and Chhattisgarh that we realized that sickle cell disease is a possible cause of maternal death, and it seemed a very plausible cause. But at the public health facility where these women died, which was mainly the district hospitals, facilities for diagnosis and management were inadequate, in fact, almost not available. So, and also the healthcare providers, their knowledge of the disease was very limited. So it was when we discussed this situation with the State National Health Mission, we came up with an action plan to improve the situation in a phased manner, and thus was born the Sickle Cell Anemia Control Mission of Madhya Pradesh in 2018. And we'll be talking about this in more detail later. Today's topic for this webinar has been selected keeping this in mind: sickle cell disease, a public health perspective. So I'll now request uh, Dr. Pallavi Govil, who's the Principal Secretary of Tribal Welfare Department of Government of Madhya Pradesh, to kindly introduce the topic to us. She's an IAS, an economist with an equally deep understanding and knowledge of social medicine by virtue of her long stint in the Department of Health as Commissioner and later as Principal Secretary. Ma'am is presently the Principal Secretary TWD in the Government of MP, where she has spearheaded several programs to benefit tribal communities, especially the particularly vulnerable tribal groups, including in health, education, nutrition, and livelihoods. We are grateful that despite her hectic travel schedule in Shivpur district, meeting with the Saharia tribals, she has been able to join us today. Thank you. Please take. Thanks.
Thank you, Dr. Raman Kataria. A very good morning to Dr. Graham Sargent, and a very good evening to everybody else that I see. Namaskar to all my old colleagues and friends. I can aap sabko mera bahut bahut namaskar. It's really a pleasure and an honor for Dr. Raman Kataria to have invited me today to make these opening remarks. And I was a little worried because I think in the beginning slide, it said something like an eminent policy maker and subject expert. Now, I wasn't sure, is he pulling my leg? I am somewhat of a policymaker. I'm just not sure on the eminence part. And as far as his kind remarks on being a subject expert is concerned, I must say I'm happy that I got the opportunity to be in the public health sphere. And whatever I've learned, it's basically been because of the association and the opportunities afforded by being in that position, as well as the association with such organizations and programs such as those run by the NHM and organizations such as Jan Swasth Sahyog, who are deeply involved in public health delivery at the field level, and not just at the field level, at the most challenging field level, which is with the tribal communities. Again, I think I've been fortunate to now from public health to move on to the Department of Tribal Welfare. Again, this has given me the opportunity to look at, to understand the perspectives of the local leadership from the tribal communities, to understand their aspirations, and to move the government in whatever way I can to slowly and gradually give them the agency to the tribal people, which they fully are capable of and which they deserve, and which they must have for their own advancement, and to be able to be decisive policy makers for their own communities, and to nudge public health systems to what they need more, rather than what we think is right for them. So with that in mind, I would like to welcome you all, and I'm very, very happy to have this opportunity to hear Dr. Sargent. I quickly read up about Dr. Sargent, and I was really, I thought, oh, golly, I should have been hearing him 5 years, prior to this, before joining. So that's my fault. I should have read more about, about all his achievements and his work. Suffice it to say that Madhya Pradesh has afforded us a lot of challenge for public health delivery systems in the tribal areas, especially because we are a state which has nearly a quarter of our population belongs to tribal communities. And sickle cell anemia has now been recognized over the past few years as to be one of the major health issues, along with other hemoglobinopathies. And slowly and steadily, we can see that government attention is being turned towards this important aspect. And from the NHM, we've been able to make a small beginning in starting creation of such systems which will be able to address the problem at scale. We are in the middle of teething troubles, I understand right now, but from my department side, we are committed to financing the program of sickle cell anemia, which will be run by the public health department in coordination with the traditional medicine departments. And we hope that as time comes, we will be guided very ably by various experts in the field, and we will be able to do a good job. At least we will be able to deliver the public health sort of efforts which the tribal communities desperately need. So I am not going to be standing in the way of the words of wisdom which we are all waiting to hear today. Thank you very much to everyone and to the organizers, Dr. Raman Kataria, for very warmly giving me this opportunity to join all of you today. And so over to you, Dr. Raman. Thank you.
Thank you, ma'am. Before we start, I just want to set the ground rules. So I just want to tell that while the speakers speak, I would request that the other people in the audience and the participants do not interrupt. And questions can be typed in the chat box, or they can be asked in the comments section. And we will then share them. So after the panel discussion, we'll go on to questions from the open house, and then they can be discussed further. So thank you, and I'll give this over to Dr. Ishani to introduce our today's keynote speaker.
Thank you, Dr. Kataria. We are honored to have Professor Dr. Graham Roger Sargent deliver the keynote address today. Dr. Sargent is a well-known figure in the international community, working on sickle cell disease for over 5 decades. In the 70s, he established the cohort study for 1 lakh consecutive births in Jamaica. He was director of MRC laboratories at the University of West Indies and studied the natural history of sickle cell disease. He helped establish the Sickle Cell Trust, later becoming its chairman. He developed several public education programs in sickle cell disease for secondary schools, while also identifying hemoglobin genotypes of over 16,000 school children. For the last 30 years, he has collaborated with colleagues on the development of sickle cell services and research in Brazil, Europe, Uganda, and the Arabian Gulf, and increasingly in India. His experience, sharp observations, and passion for improving the quality of life of each affected person has earned him the respect of all and several laurels, including recognition by the British government in 1981 with the award of the Companion of the Most Distinguished Order of St. Michael and St. George, and by the Jamaican government with the Order of Distinction Commander Class in 1996 and the Order of Jamaica in 2015. He has over 480 research publications and 4 books to his credit. May I now request Dr. Graham Sargent to kindly share his views.
Good morning, Jamaica. Good evening, India. It's a pleasure to be invited to this meeting. I look forward one day to kind of getting there in real life when things are a little bit easier. I'm having a little bit of volume problem with the volume, and I'm just wondering, can everybody hear me all right? Can everybody hear me?
Yes, yes.
Yes, very much.
Fine, sir.
Yeah, muted, so that's why.
Yeah.
You can hear?
Yes, yes, absolutely.
All right, okay. I'm just told my internet connection is unstable, but as long as you can hear, that's fine. Good, so let me move on to the next slide. The next slide. Thank you. This is the traditional distribution of the sickle cell gene and hence sickle cell disease. Most of it, of course, has been recognized to be in sub-Saharan Africa, where the frequency of the sickle cell trait may be as high in some communities as 30 or 40%. And from there, the gene moved in large numbers to South America, North America, and the Caribbean during the slave trade. And then latterly, directly from the Caribbean to England with voluntary immigration. And then latterly, a direct stream of immigrants from West Africa, particularly to the UK. So most of the disease that is seen in people in the west of the world is of African origin. And I think one of the lessons we have to learn today is that it is not confined, as you know well, to people of African origin. If you look at the worldwide distribution, you can see the disease in Greece, Turkey, Saudi Arabia, and of course, central India. If we could move on to the next slide. Next slide, thank you. This is the simple genetics. If you inherit the sickle cell gene from one parent and a gene for normal hemoglobin, normal adult hemoglobin from the other, you have the sickle cell trait, or the AS genotype. This is not a disease. These people are perfectly well. But if somebody with the sickle cell trait has children by somebody else who also has the sickle cell trait, there are a variety of options. There is a 1 in 4 chance at each pregnancy that the child will inherit the sickle cell gene from both parents and have so SS disease. Oops. Can we go back? Thank you. There is also a 1 in 4 chance that the offspring, sorry, can we go back again? Thank you. Just stay with this slide until I ask for the next one. No, back please. Can we go back to the previous slide? Is it possible to get back to the previous slide?
Raman, is there a problem?
Sorry, there is a problem with getting back to the previous slide. All right. Right. Perfect. That's right. Just stay on this until I ask for the next slide. So you have 2 parents, both of whom have the sickle cell trait. They may be both fit and healthy, but they can have a variety of offspring. Sometimes a child that is absolutely normal, AA, a 2 out of 4 chance that the child will have the sickle cell trait, like the parents, and a 1 in 4 chance that the child will inherit the sickle cell gene from mother and father. Now, the next pregnancy, the odds are exactly the same. And the next pregnancy, the odds are exactly the same. So you could have an SS child as your first offspring. You could have an SS child as your second child. You could have an SS child as your third child. For each individual pregnancy, the risks are always the same. So it's very important to realize this, because often people think, oh, well, it's simple. If it's 1 in 4, they will only have 3 children. And of course, that's not the way genetics works. Let us move on to the next slide. Thank you. And here we are at a village in northern Greece. And here are both parents on the left who have the sickle cell trait, and their 2 children both have SS disease. White-skinned, blue eyes, not the traditional disease that people expect. The next slide. And here we are at Adana on the south of Turkey. And there, both parents have the sickle cell trait. The daughter on the right has the sickle cell trait, and the daughter on the left has SS disease. Next slide. Thank you. Now we're north of Israel, and this is a Bedouin tribe. And on the right are a father and a mother, both of whom have the trait, and their 2 children, one on either side, have SS disease. And the lady in the middle in the orange dress is her sister, and she has the sickle cell trait, and her child has SS disease. And then the lady on the left is the sister of the 2 other ladies, and she has SS disease herself. So the point that we're making is that even in an atypical area such as Palestine, the sickle cell gene and the sickle cell trait are still important problems. Next slide. Now we're at Qatif Central Hospital. Sorry, Qatif General Hospital. This is the old hospital in Qatif, which is in the eastern province of Saudi Arabia. And in Saudi Arabia, in the eastern part, in Qatif and Hafuf, 25 to 30% of the population have the trait. And the gentleman is a father who has the trait. His son, lying in hospital, is sick with bone complications of the disease. Another son who is visiting also has SS disease and is perfectly well. Next slide. And finally to India. And this was a study that we did with Professor Bimal Kaur at Birla Medical College in Odisha, attached to Sambalpur University. The year is 1986. And here on the right is a gentleman who is a doctor, and he had no idea he had the trait. And on the left of his wife, a lady who has a PhD in economics, and she had no idea she had the trait. And in fact, their first child in front is SS disease. So even in this community, intelligent, educated people do not realize that the trait occurs in their population. Next slide. So this is just a glimpse of Jamaican countryside, in some ways not very different from Indian countryside. And we've been very privileged over the last 54 years to follow many patients over a long period of time. Next slide. And this has been possible. This is an early slide. The year is 1967. As you can see, we were then funded by the Wellcome Trust. And in fact, they gave us a mobile clinical unit, which you see here in the parish of St. Elizabeth, which is in the bottom left-hand corner of Jamaica. So we have the ability to follow our patients in the island of Jamaica. The next slide. The next slide, please. And this is a slide from Professor Sudham Karte. And this is of Indian countryside, a village of Dargaon in the north of Maharashtra. And there, next slide, please. You will see the sickle cell unit created by Professor Karte and his organization from Pune. You will also see the lady standing on the doorstep is Beryl, my wife, and she is a hematology technologist who has been invaluable over the years in many ways, but particularly in developing the laboratory aspects of the disease. Next slide. So now we're going to try and learn something about the disease. And this is a study that we did with Professor Kaur at Birla Medical College in 1986. And we first visited Birla at the invitation of Professor Kaur in 1985. And he said, we've got lots of children here, and they have joint pains, they have jaundice, and they're anemic, and they have a positive sickle test, but we do not have electrophoresis, which is the test needed to make the diagnosis. So the following year, we went and worked with Professor Kaur again and carried an entire laboratory to study some of his patients. And here you see, excuse me, here you see Mrs. Sargent in the front, a volunteer lady called Sue Sir, who's a nurse who came all the way from Jamaica. That behind her is Andreas Kulotzik, who is now professor of pediatrics at Germany. And then his wife, Martina, who is also a doctor who did a lot of the blood tests. So now we're going to learn something about what we learned in that study. Next slide. Right. Now, we spent a little time sorting this out, but what we're doing here is we're looking at the distribution of hemoglobin levels. The red columns are Jamaicans, and the orange columns are the Indian patients in that study in Odisha. And the lesson here is that Indian patients have a hemoglobin level which is nearly 1.5 grams on average higher than Jamaicans. So you see the orange columns are shifted towards the right-hand side. Next slide. And here we're looking at reticulocytes. Remember, reticulocytes are immature red cells that give you some idea of the degree of bone marrow activity. It is always increased in patients with SS disease. And if you look at the red cell, the reticulocyte counts in the red columns, Jamaica, and the orange columns, India, you can see there is a shift towards lower reticulocyte counts. Now, you may think reticulocyte is a fancy test, but when I look after patients with sickle cell disease, the first test I need is a hemoglobin. The next test I need is a reticulocyte count, because that tells us how the bone marrow is responding. So we now know that Indian patients tend to have higher hemoglobins and they have lower reticulocytes. Reticulocytes are an indicator of the degree of red cell destruction. So this suggests that patients in India have less red cell destruction from their sickle cell disease. And the next slide. This shows the distribution of fetal hemoglobin. Now, fetal hemoglobin occurs in babies and switches off usually in the first year of life. In SS disease, it persists for longer, and that persistence is very important because high levels of fetal hemoglobin in older patients interferes with sickling and causes more mild disease. So here you see the red columns, the Jamaican data, and you can see Indian patients are shifted towards much higher fetal hemoglobin levels. Next slide. So let's summarize. Indian SS disease and hematology, they have higher hemoglobin, they have lower reticulocyte counts, they have high levels of fetal hemoglobin, and something we haven't talked about, alpha thalassemia, which is another genetic condition common in Indian patients with SS disease. This makes the hemoglobin molecules more dilute within the red cells. So both high levels of fetal hemoglobin and alpha thalassemia tend to cause more mild disease. Clinically, what happens? Well, the spleen persists for longer. And the spleen is very important, sits in the ribs under the left-hand side and of the abdomen. And it's there to take out damaged red cells and to take out bacteria that get into the blood. In sickle cell disease, there are so many damaged red cells that that filter no longer works properly. And so people tend to be prone to septicemias, to overwhelming blood infections. Bone pain crises, the so-called sickle cell crises, are still common, even though they have high levels of fetal hemoglobin and frequent alpha thalassemia, which should have made it more mild. But leg ulcers, which occur in 30% of Jamaican patients, are, in my experience in India, rare. And priapism, which occurs in nearly 40% of our SS males, is also rare. So we begin to see differences in the disease. Next slide. All right, so what are the challenges in Indian sickle cell disease? And we'll go through these in order. The first is make the correct diagnosis. Next slide. Thank you. And you've already seen the slide at the top left. The sickle cell gene occurs irregularly in India. It occurs across the center of India in quite large numbers. There's also a focus of the gene in the south, in the north of the Nilgiri Hills, where it was first described. But there are whole areas of India where the sickle cell gene does not occur. So it is not all over the continent. Now, what is all over the continent is the gene for beta thalassemia. And if you look at the bottom picture, you will see here the relationships of somebody who has the sickle cell trait, AS, and another parent who has the beta thalassemia trait, A beta thal. And if you look at the genetics again, you can see there is a 1 in 4 chance that the child inherits the sickle cell gene from one parent and the gene for beta thalassemia from another parent. And so they have sickle cell beta thalassemia. Now, you may think this is unimportant, but in fact, it is not. In a study that we did with Dr. Dipti Jain in Akola, we found, in fact, that nearly half the patients actually had sickle cell beta thalassemia. And that does change the manifestations of the disease. So it's important to have the correct diagnosis. The next slide. 2, management of anemia. And it is tempting once most Indian patients have hemoglobin levels between 7 and 10 grams. If it falls outside that range, there is always a reason. Find out the reason rather than just obscuring the situation by transfusing. Next slide. Next slide. We're still waiting for the next slide. Thank you. One of the reasons is hypersplenism, a very large spleen. And the left-hand side, 2 pictures are from patients looked after in Valsad by the blood bank there. And this is a young boy at the time who has this huge spleen marked with a pen there going down into the right iliac fossa. And at that point, at the age of 12, he had had 69 transfusions. The spleen was removed, and you can see the picture after splenectomy, which is the removal of the spleen. And ever since then, he has required no transfusions at all. So make sure what the cause of your anemia is. On the right-hand side is a picture from Professor Carr's clinic, also a child with hypersplenism. And there you see the traditional approach of scarring, branding, which of course achieves nothing except a nasty scar. Next slide. Next slide, thank you. Number 3, cause of fever. This is one of the most common causes of hospital admission. And once again, it's very important to investigate these children properly and, if possible, develop facilities for blood culture, which is absolutely routine in the investigation of anemia. And the last, next slide. And this is beginning to address the issues of newborn screening. And we're fortunate because Jamaica was one of the first countries in the world to have newborn screening. And in fact, it's very simple these days. You use a Guthrie card named after Robert Guthrie from Buffalo, and it's got a clerical end and a little piece of blotting paper on the right-hand end in which you collect a drop of blood. In Jamaica, we do it as the umbilical cord is cut. So you need the cards, which are cheap. You can make them yourself. We need babies, and you've got plenty of babies, as we have in Jamaica. Next slide. Next. And you also need HPLC technology. And this, unfortunately, is more expensive than it should be. But I think you can make the case to find a private sponsor to try and get that technology available. Because newborn screening will eventually have to be one of the main approaches to the disease in India, certainly in actually documenting what we call the natural history. Next slide. And this is the last slide, I hope, if we see it. Thank you very much for inviting me to take part. Thank you.
Thank you very much, Dr. Sargent, for having given us this lucid exposition. I'll now give over to Dr. Ishani to introduce the next speaker.
Dr. Jyotish Kumar Patel from Bardoli in Surat district, Gujarat, has a special interest in sickle hemoglobinopathy. He is chairman, Vision Mission Foundation, Medical Foundation for Rural Health and Research, Sickle Cell Treatment Center, Shishudip Hospital, Bardoli, Gujarat. Sickle Cell Swa Suraksha Abhiyan is a model project designed to address sickle cell issue with community participation based on his experience of over 25 years. He has been involved and published several papers. He is a motivational speaker and also interested and active in politics. Dr. Jyotish Kumar has received many accolades and awards for his work. May I now request Dr. Patel to share his experiences.
Yeah. Hello.
Yes, Dr. Patel, you are audible.
Yeah, I am trying to upload my slide because you are able to see or you are not able to see?
Not yet.
Not yet. Okay. Who can share? Only host or all participants? On who can start sharing? I am not able to see, the bullet which is active for me. Hello.
So, Dr. Patel, you are a co-host and you can share your slides.
But then what I am trying to share it, the only thing is that there are 3 tabs, and in which the second and the third one is not active.
So you click on share slides, and then on the desktop you will find 2 or 3 screens. The one which is showing the slides that you have to click, you click on that. After you click on that, go back to your screen and start the slide. Go back to your PowerPoint and start the slide.
I have gone back to my PowerPoint slide.
No, you have not yet come. You have not yet started sharing your slide. So now you don't need to go to your PowerPoint slideshow. First, start sharing. To start sharing, click the share screen at the bottom. There's a green button.
Yeah, there is a green button. Yes, I see that. There is a green button.
Click on it. You click on it.
Yeah, I am clicking on it. It is not getting it. That is the problem.
Okay, so can I suggest that if you can send your presentation to us, and meanwhile we'll start with the next speaker. So then soon after.
Right now I'll be able to do that. Not a problem. Okay, I am mailing it to you. All right, fine. Not a, you go ahead with the other presentation. No problem, sir.
Okay.
Yeah.
Moving on, Dr. Raman Kataria will be presenting the work we have been undertaking in Madhya Pradesh. Dr. Raman Kataria is a general and a pediatric surgeon trained at AIIMS Delhi and has co-founded Jan Swasthya Sahyog in 1996 and has been working in Chhattisgarh and Madhya Pradesh ever since. Jan Swasthya Sahyog runs a comprehensive health program with women village health worker-led primary care and intensive outpatient, inpatient, emergency, critical, obstetric and surgical care at the referral center in Ganyari. Dr. Kataria is keenly interested in maternal and newborn health and system strengthening in public health facilities, which has been running as a JSS program for a few years now. He is also a strong advocate for improving young child nutrition through rural creches. I request you to kindly present our work. Thank you.
Thank you, Ishani. Is my presentation visible? Okay.
Yes.
Yes.
Yes. So, my talk is titled Sickle Cell Disease Screening, Diagnosis and Management in Madhya Pradesh. And this is deliberately done because all three components are extremely important and need to be done hand in hand. So there were several challenges that we faced when we started the sickle cell anemia control mission. And I'll just enumerate them. The first one was, of course, even the diagnosis of establishing anemia, because hemoglobin estimation at most facilities was being done using age-old methods which were not reliable. The cause for anemia, of course, the lab workup for anemia was very available at very few centers. Management, the availability of drugs for sickle cell and of blood was again a problem. And of course, there was problem of knowledge, of skills and attitude of the care providers at that time. We wanted to ensure comprehensive care at the district hospital and FRUs. And we started by training of medical officers and specialists, 74 of them, nurses, and also lab technicians, 65 of them, not only to perform solubility test for screening for sickle cell disease and hemoglobin gel electrophoresis, but also hemoglobin estimation using digital hemoglobinometers, which could be used 24/7 round the clock in these facilities. The pharmacy, we trained them and also ensured the availability of folic acid, hydroxyurea, and tramadol for pain relief. We ensured that these drugs were available in the rate contract and a narcotics license was in place in these facilities. Blood without replacement and free of cost, and supportive supervision while this was being done. We started with screening using a team, 5 teams. Each team consisted of 3 members, 1 A&M, 1 lab technician, and 1 resource person in each team. The A&M was deputed with the task of pre-screening counseling, sample collections, and antenatal checks of the pregnant women. So with these 5 teams, each team was able to collect on an average between 40 to 60 samples in a day. We started with screening of pregnant women during their antenatal clinic visits to the VHNDs, sub-centers, the primary health centers, the CHCs, as also door-to-door. We did hemoglobin estimation in the field using the simple copper sulfate method. And those with hemoglobin of less than 7 grams per deciliter required double the volume of blood. That means instead of 20 microliters, it required 40 microliters into the reagent that was used for the solubility test. So this is showing what the solubility test looks like. And you can see here that in these tubes, where you can see that black lines are visible through the tube, it means that the solubility test is negative. And when the fluid in the tube is turbid and it doesn't allow the black lines to be seen, that means that it is solubility test positive, which could be either AS or SS. So when we continued screening, once we finished the screening of pregnant women in the entire district, the scope of screening was enhanced to include the husband and first-degree relatives of the sickle trait or sickle disease persons. And in the 3rd phase, we took up screening of school children, including those in the Anganwadis, primary, middle, secondary, and high school children. For the diagnosis in these facilities, we ensured through reliable hemoglobin estimation, using a digital colorimeter or a Coulter counter, hemoglobin electrophoresis, HPLC when it was made available, and we used an app to collect data offline in the field, and all this while ensuring that diagnostic test reports reached those who were affected and were linked to comprehensive care. This is the hemoglobin electrophoresis that has been developed by the JSS Appropriate Technology Department. And Essentially, it is a very simple machine with a power pack, and it cuts the cost of the machine to almost 1/4 of the usual cost in the market, or more than that. And the per test cost also comes to around 20 to 25 rupees per test. So that is also a very significantly small cost for per test. And once the patient is diagnosed with sickle cell disease, patient is given an identity card or an information card where all this information is recorded. And on the back of this, there is a counseling checklist and a note for the doctor, as well as a number which is for helpline. So in addition to handling the patient's problems and myths, we also had to handle many medical myths which were prevalent, not only amongst patients, but also amongst healthcare providers, such as sickling of any type, whether AS or SS is bad, they shirk work, they are not the best students or employees. Blood transfusion services are the main technological need for treatment of sickle cell disease, or sickle cell disease presentation is very mild and can be managed without opiates and hydroxyurea in India, or that people with SS disease don't get falciparum malaria, or that premarital counseling can reduce the occurrence of SS disease. So when we did the initial counseling, we talked about these myths also. We talked about the illness, why it had happened to them, what were the issues, the expected course, the do's and don'ts, diet, their exercise, drugs, which ones are to be used and how to obtain them, and the follow-up tests that are required, early home management in case they develop any pain symptoms, and red flag signs when they need to go to the hospital, and also provided them with the helpline number and introduced them to their peers so that they could discuss their problems with them, those who were already on treatment. And the management consists of hydroxyurea, folic acid, availability of paracetamol and tramadol, given SOS. Monthly supplies were arranged from the public health facilities, and 2 monthly complete blood counts and 6 monthly serum creatinine and liver function tests were done in monitoring these patients. And for any fever or pain episodes, emergency room visits were advised. This is one innovation which helped significantly in improving compliance to treatment of these patients. And this was one of the lessons we had learned from our work here in Chhattisgarh. The patient support groups or the peer support groups. These are groups of 40 to 50 patients who meet every month at the facility where they receive treatment. The meetings of these groups are structured to help patients talk freely about their problems, share experiences with each other, learn from each other and from the counselor or doctor about prevention of acute episodes and their early home management. The doctor examines the patients at these group meetings, prescribes tests and then medications as required. The helpline number, of course, is shared in case of an emergency and also when they need blood. So this has helped to improve compliance significantly. This is a picture of one of the peer support group meetings going on, and the doctor is sitting in this corner on the table and chair here while the patient is being seen. So these are the results that we saw of our screening and diagnosis. Overall, we have worked in 6 districts in Eastern Madhya Pradesh, done intensive work in 2 of these districts, Anuppur and Dindori. And the total number of patients, including the pregnant women, which are shown in the upper part, the total number of patients screened was, per person screened was 1,31,317. And out of which 17,842 or 13.59% were solubility test positive. After electrophoresis, 13,426 had trait AS, 10.22%, and 1,603 patients, that means 1.22%, had sickle cell disease or SS. There were a significant number of patients who did not have their confirmatory tests done for various reasons. These were 2,521, total of 14% of the cases. So this is the distribution age-wise of sickle cell disease patients. And as we can see here, majority of the patients are in the category of 7 to 12 and 13 to 18, 24% each almost. And then as we go further higher in age, the number of these patients decreases, possibly because most of them have not survived beyond this age, beyond a certain age. We also have fewer in the 0 to 6 age group because we were focusing on school going, including Anganwadi going children. That means 3 to 6 year age group. The socioeconomic status, as we can see here, most of them were poor people, the below poverty line, and the Deen Dayal. Gender-wise, male-female was almost equal. And if one looks at this, the class or the caste status, in the total patients who were taken up for screening, there were the predominant caste was the tribals, the scheduled tribes, and then followed by the other backward castes, which were 38%, and the scheduled castes, which were 2.1%, and then the general category 8.44%. But when we come to the sickle cell disease patients, we find the SS patients that a large majority of them are the other backward castes, 50.88%, and 31% are the scheduled tribes. This is the anemia status found during screening, and we can see here only very few patients they were either mildly or not anemic. Most had moderate anemia, 332, or severe anemia, 43 patients. And this is amongst the general, that means those who were screened, this is amongst the SS patients. And when we look at the total, the screened population, that means irrespective of the disease status, we find that there is still a high prevalence of anemia, both mild and moderate anemia, as well as severe anemia in the general population. So when we talk about comprehensive care, as Dr. Sargent has pointed out, it is important that we have universal screening of the population beginning from the newborn period and family screening and diagnosis. We should be able to provide outpatient care, good outpatient care using penicillin prophylaxis early on, pneumococcal vaccine, folic acid, educating the patient, including about the possible choice of partners, use of hydroxyurea and pain medications. And whenever they require inpatient care, the management of their complications, crisis, and easy access to safe blood. And of course, having a voice or say in their management, whether it is during their studies as children or work conditions, and recognition of their special needs. So this is my last slide, talking about resource distribution within sickle cell disease. This is more of an open question as to how resources should be distributed or priorities should be set when we are looking at sickle cell disease, because we all know that resources are limited. And with these limited resources, what should be our priorities, whether it should be, I'm not saying this is one pitted against the other, all may be important in their own right, but we of course have to set our priorities and see how much we need to invest where. So, and there'll be experts in the panel who will also talk about this, whether it should be at the screening at the hospital level, screening at the community level, diagnostic tests using hemoglobin electrophoresis or HPLC at the district level, in management of ongoing chronic in the stable state at block level or primary health centers, in managing acute crisis or complications at the district or block level, in community education and mobilization for testing and early pickup of complications, or developing facilities for antenatal diagnosis, which is high-end and high technology, or facilities for bone marrow or stem cell transplant, or going for basic lab research, which includes genetic research, the studying the deletions or the translocations and such stuff, or research into alternative systems of medicine, including the Ayush for sickle cell disease care. So I'll end here. Thank you.
Yeah. May I now request Dr. Patel to share his experiences?
Sure. I think you have my slides. Thank you, Dr. Raman Kataria, and thank you, Dr. Sargent, for asking Dr. Kataria to involve me in today's talk. Thank you so much. Can I have a first slide, please? Sickle cell disease in India is now, can you hear me, everyone? Hello? Hello?
Yes, we can
Yes, sir,
hear
you are
you and
audible.
see your slides.
Okay, so can you make it a slide slow, please,
Slideshow.
from your end? Sickle cell disease is a complex disorder that we are having in our medical practice. And it is not so easy to manage every aspect of sickle cell disease because it has got a multi-system involvement. Can I have a next slide, please? Can I have a next slide, please? Excuse me. Can you hear me?
Yes. Yes. Give us a
Yes.
second.
Can I have a next slide, please, madam?
Yes. Trying to, but there seems to be some problem. Give us a
Is it?
moment.
I think you should put this on slideshow mode.
Yeah,
And
that
go
is
to
what.
full screen, and then you will find it
Yeah.
easier.
Yes, yes. If you, yeah, I think. Perfect. Yeah. Next one, please. Next one, please. Okay. Today, we do not celebrate World Sickle Cell Day. Instead, we take one step forward to support person, family, society affected by sickle cell as a part of responsibility assigned to us as healthcare provider. Every country has a law of land, but here law of nature applies. Human is trying to defeat nature, but it is unethical by nature's law. Let us page for a better care and pray for all who are suffering from sickle cell disease. Next, please. Next, please. Sickle cell Swasuraksha Abhiyan, as name implies, sickle cell affected community takes this issue in their own hand in the form of swa. Swa means own self. Suraksha means protection, and abhyans mean a kind of motion. From the people's initiative, we adopted 11 villages, and what we did, I will show you in the next slide. Next slide, please. What was most important was that any issue, if we want to address it properly and if we want to give a longevity, what we need to do is educate and sensitize society. There is a need of people's participation. There is a need of screening and identification, day-to-day care for all patients who are affected with access and combination, emergency care for their needs, and marriage counseling. Next, please. Considering all these aspects, we designed a project in such a way that the formulation of the policy was from the people and not from the doctors or the higher authorities. What we need to understand here is, if it is to be having a longevity, in that case, what people needs, that should be focused on, so that it has got more and more involvement of the society, and their involvement will allow us to do to give advantage of medical science to all those who are suffering from sickle cell issue. Next slide, please. It has to be a people's participation. Purpose is to make them aware of sickle cell issue and not to make them frightened. Many times what is happening is that we go with a medical issue to the society and tell them that this issue will have these many challenges. Rather than that, it is important to tell them that the society can have issue of diabetes, hypertension, or any relevant other disorders. In that way, sickle cell issue is also one of the disease or one of the genetic defect which is there in the society. So it is our effort so as to find out who are carrier, who are sufferer, and who are the normal individuals. Next slide, please. So village leaders were asked to come at our place. They were given slides of presentation and were educated. Next, please. Next, please. They went to village street and educated people at large, and likewise, all streets were educated. Next, please. The whole village was sensitized for the issue of sickle cell, and that is how they came forward with their own ideas how we can go ahead with this project of sickle cell screening. Next slide, please. Having done this, we went further and we just asked them that what you will be able to do from your end. They said we will register all our people of the village streetwise. We will make necessary transport of those people to the venue of the screening. We will help you to we will help you. Previous one, please. We will help you to distribute these cards to each and every family members. So registration, transport, and card distribution. These were the responsibilities which were assigned to the village people. What we did on our part, we went with the team. We had a sample collection. We did solubility test. We did electrophoresis. We identified normal, sickle cell trait, and sickle cell disease individuals. One more thing that we did blood group analysis of all samples so that whenever there was a need of blood transfusion, at least there was a family support or a village support for the blood donation. Next slide, please. And here is the data. We did survey of these 11 villages, 7,304. 25.35% was the positivity rate with solubility test. 23.82 were sickle cell trait and 1.53 were sickle cell disease. And rest 74.64%, they were normal, they were AA. Next slide, please. Now this result was revealed in the form of card to each and every family, and they were given all cards in a single cover so that it is preserved properly and it is not lost. Now, why all village persons should be screened? There was an argument by so many our co-workers as well as at times authorities also, that why you want to screen all people. The reason was only one, that we need to identify all because there is a variation in the manifestation of the disease. We have seen a patient who is less than 1 year of age with manifestation related to sickle cell disease, and we have seen a patient who is 50 years plus who was asymptomatic for symptoms of sickle cell disease. So much of variability in the symptoms. That is why it is important that we try to survey all people. Number two was, it is also important to identify that normal individuals, they are very helpful when there is a question of blood donation. And at times, it is very difficult to manage blood transfusion without the support of blood donor. So that was another point. And the third point was that otherwise also we were interested in identifying who are sickle cell trait individuals in the community, which will help us in reference to the marriage counseling. Next slide, please. Having done this thing in the community, What we did that we appointed one sickle cell health worker from the community, which was identified by them. We gave him electronic thermometer, blood pressure instrument, and we gave him all necessary medications for day-to-day care. Doctor, they used to go at 3 months interval for checking all these sickle cell disease patients. Whenever there was a need of an emergency, at that time, these patients were guided to a referral center. There was a need of frequent monitoring during pregnancy, which was done, and marriage counseling was given to all who were there. And this was done in the form of village assembly. The whole village was gathered, and at that time, with the PowerPoint show, each one of them were guided about what AA has to consider about the marriage, what sickle cell trait has to understand, and what sickle cell disease has to understand. As we are seeing here, who is the top priority in all this? Obviously, it is sickle cell disease patients who are the sufferer. So we have to give them a 24 by 7, 365 days care as far as emergency is concerned. Next slide, please. Next slide, please. At Sickle Cell Treatment Center, which is equipped with all machineries, it is a tertiary care unit. We used to get patients for pain management. There was a need of at times of blood transfusion, exchange transfusion. There was a need to manage intracranial complications, and we did a couple of surgeries also. There was a need to manage obstetric management in a perfect way so as to prevent mortality. And there was also a need of mechanical ventilation. CT scan facility is mandatory if we want to manage critical patients of sickle cell disease for two reasons. One is to identify cases of intracranial complications, and number two, now COVID. Laboratory facility obviously is there. It is a basic requirement in all centers. So what we did with this critical care center, I'm giving you further information. Next slide, please. Next slide, please. Here it is. We had 1,476 admissions in last 2 years with a mortality of 1.69%. Majority they survived, went home. And the major cause of mortality was acute chest syndrome. The next was acute sequestration crisis. Third was septic shock. Number 4 was intracranial hemorrhage. Number 5 was multi-organ dysfunction syndrome. 2 patients we lost because of COVID pneumonia. 1 patient we lost because of acute myocardial infarction. So if we give them a proper care and if it is a team approach, I think majority of these patients, they can go alive even with the worst complications they have. Next slide, please. The surgical patients that we had, we did splenectomy in 4 cases. They all had hypersplenism. We did cholecystectomy in 2. Hip replacement we did in 11 cases, and 6 patients we did brain surgery, and 50% of them they survived. Next slide, please. Obstetric management is really a key, especially in Gujarat also. Sickle cell disease and pregnancy was one of the #1 cause of mortality, which has gone down significantly now. Next slide, please. We did obstetric management with the help of the obstetricians, full-time obstetrician that we have. And as we see here, that 7 had normal delivery and 26 patients, they had emergency cesarean section. I would like to mention here that there were issues wherein there was a premature labor, there was intrauterine growth retardation, there was sudden decline in the amniotic fluid, and they had a dry labor, and there was chance of intrauterine fetal death. So these are the situations in which we had to take out baby on emergency basis, and that is why what we are seeing here is there is a higher rate of cesarean section in our patients who were having pregnancy and sickle cell disease. But let me tell you that all mother, all babies, they went home alive. Next slide, please. Next slide, please. So what I conclude from these, the sickle cell program should have more people focused approach rather than it is designed in the offices and then they are asked to follow it. Need to identify all. Sickle cell disease case must be assured to have day-to-day care as well as emergency care. Obstetric care differs significantly and need to be managed with expertise. Chronic organ damage is a concern nowadays and need to develop monitoring and managing facilities all this. Need to encourage every sickle cell disease individual to enjoy life. They can go to school, they can go to college, they should be employed, they should be encouraged to work, they should be encouraged to marry, they should be encouraged to have a good social life. And I think we should not have a way in which they are stigmatized. This is the issue that we are facing in the society. So a positive approach is very much essential. Next slide, please. Next slide, please. I think. Next slide, please. Can you forward it, madam? I think that was the last slide where I have mentioned that sickle is not simple. Every case of sickle cell disease behaves in a different way. We have a patient who has come for the first time in the hospital with acute chest syndrome, diagnosed at the age of 24 years and did not have any medication in the past, straightway coming to us with acute chest syndrome. So this kind of variability in the symptomatology, I think, is a concern for all of us. India needs a very categorical management of these patients, and I do not think that anyway Indian scenario of sickle cell disease patient is milder in nature. I do not agree with this. All patients with sickle cell disease are having some or other severe complication. And what is the key is, whenever there is a severe complication, it has to be managed very effectively and efficiently so as to make them survive. Thank you very much for inviting me and allowing me to share my thoughts on sickle cell issue. Thank you so much.
Thank you, Dr. Patel. We will now move on to the panel discussion. May I now request Dr. Ms. Chavi Bharadwaj to share her views. Ms. Chavi has probably not joined as yet. We could then move on to Professor T. Sundaraman. Dr. Sundaraman is a public health expert. He is former executive director of the National Health Systems Resource Center and former dean of School of Health System Studies at the Tata Institute of Social Sciences. He has been actively involved in the health and education movements in India with Jan Swasthya Abhiyan and All India People's Science Network, of which he is a founding member. Dr. Sundaraman is currently the global coordinator of Public Health Movement, a global network of grassroots health organizations, health activists, civil society organizations, and academic institutions around the world with presence in 70 countries. He has written over 50 books, on health issues and a number of articles that have been published in peer-reviewed journals. May I now request Dr. Sundar Raman to please share his views.
Yeah, you can perhaps take the share slide off so that they can see me on that. Thank you for giving me this invitation. We have already heard three main presentations. One, an international experience, which is also grounded in India, and then from our guest speaker. And then we have heard two presentations, one the Madhya Pradesh experience, which was data rich, and then the Gujarat experience, which is in some sense intervention rich also. We have a number of scenarios that we have got. Now, I have been seized of this problem of sickle cell right from the year 2003-4 that I came to head the SHRC in Chhattisgarh. It was there till 2007. And since then, I have been in touch. And we have had a number of workshops. We have had a number of policy briefs on sickle cell disease and the public health approach to sickle cell management. Now, there are many issues that this presentation has raised. First, that as compared to something like 2 decades back, there is a whole range of diagnostics and treatment opportunities that we take for granted now. Pneumococcal vaccine, folic acid, hydroxyurea, surgeries, these are now sort of taken as if they were always there. But this was something that has changed the way we look at it. The second, I think, big issue is that we are now much more prepared to actually engage in an overall prevention and control effect, where the aim of it should be a reduction of both morbidity and mortality due to sickle cell disease. And if we define a public health program that is not really about, okay, I am in this hospital, what should I provide for sickle cell disease? That is one way of looking at it. Those who come to me, I treat. Those who don't come to me, is not my botheration. But when I am talking of a public health approach, I mean that I am, say, in charge of this district. Then it is my responsibility to see that those who come to me, I provide relief or treatment for, but I also search out and make sure that I am able to reach to all those latent people who have suffering but have not been diagnosed, either misdiagnosed and mistreated or not even sought care. So you really require to look at that. And then what can be done to prevent this disease from actually coming into vogue on that. So I think this particular area is a number of options, is a number of possibilities. Raman in his presentation had highlighted 10 possible areas for intervention. Let me say they are not possible areas. All of them, in a sense, are mandatory areas. All 10 needs to be done. But given our constraints and given what do we know about the effectiveness of any one of those 10 interventions on the field, and what do we know of the cost effectiveness of any of these interventions on the field. So therefore, I think what we have arrived at today, after 20 years, where we know a lot about public health, we have generated a lot of public health experiences, we know the interventions, we have new tools, is the question of prioritizing our interventions. I think the time is ripe now for having a proper health technology assessment and making choices on what we prioritize, guided by cost effectiveness studies, which help us to evaluate different interventions and the progress that they provide. For example, is it really worth our while to screen every adolescent boy and girl and give them counseling in the hope that they will, a person with one trait will not marry another with another trait? Is it useful? Is it, are there other factors and other background issues why that is not a particular option? But it may be far more useful to do something else. Like, should we instead just look at doing a solubility test in the mother and the father, so that we can suspect that the child may be sickle cell disease, and those children you take up for a newborn screening with electrophoresis or HPLC, and then subsequently you put them on treatment from early life. Therefore, they will have least issues. So should we invest in newborn screening? And newborn screening is not going to be easy in India because the births occur in a very widespread territory, whereas you can make HPLC available at best at your district hospital level. And therefore, are there tests that we can make more reliable, that can be done, point of care tests that we can innovate, that can do for newborn screening? So the usual solubility test is not very useful there. So do we have a choice? Should Madhya Pradesh go for newborn screening for sickle cell disease and try to cover all sickle cell, at least in endemic districts or in endemic subgroups of the population? Or should we look at community-based screening for adolescents? What would be a much more productive approach at a population level to this control? It's easy to say do all of it, but given the constraints that we have, we will need to choose within that. And then the question, therefore, is also of what is the level of treatment that we offer? What is the balance between our investment in, say, bone marrow transplantation and stem cell treatments and genetic studies as different from, let us say, basic giving of hydroxyurea and folic acid on a universal scale? Now, again, we just can't say for a state, especially a state as large as Madhya Pradesh, that we choose one or over the other. But there is obviously a question of a stagger in what do we make available at the primary health center, what do we make available at the district hospital or block center, and what do we make available at medical colleges. Now, I see no reason why in the medical colleges we should not make the whole of all the treatment modalities available. Medical colleges are tertiary care hospitals, and they should not be run at the level of capacity as district hospitals. But then at district hospitals, what is the level of care that we do expect to give? And then the primary health care, the basic, first we must admit of a notion of primary care for sickle cell disease, which includes screening, detection, and the treatment of minor illnesses, and regular folic acid, pneumococcal vaccine, and is hydroxyurea on a regular basis wherever indicated, and relief of pain. This much, I think if we do our studies, we will need to demonstrate it, should be available at the level of the primary care. There's no reason for this to be shifted to the tertiary care physician or the secondary level care. Whereas management of sickle crisis emergencies will happen at the higher level, at the secondary care level. And genetic work will occur at the medical college level. So this sort of distribution, the experience that we have, because a senior person, all three of you are very senior people in your respective domain. You can go to a village, you can provide all levels of care. But if we are building a system of caregiving, we will have to, one of the challenges is to define what care can be provided at the primary level, what at the secondary level, and what can be provided only at the tertiary level. So the commitment to provide all levels of care should be there. There is also, therefore, the public health goal that we set ourselves. My own understanding, looking at the priorities, is that we should be able to reduce mortality and the loss of life expectancy due to this disease. We should be able to identify them early enough and be able to sustain their treatment so that they have a relatively normal lifespan. I think this is the immediate goal that we can set ourselves and achieve. The larger goal of being able to actually prevent new cases, will take a longer time, must take awareness, must take a certain amount of building. Immediate campaigns of screening everybody, all adolescents, and giving counseling, while such services are made available, universalizing that may not have the maximum impact. So one would need to have that going at some level, but the focus really requires to be that the needless suffering and pain, which is due to sickle cell disease, which is there, as all of your studies show, in only 1.53% or less than 2% of the population. That is a large number. 2% of the Madhya Pradesh population is a huge number. Okay, and that we should be able to address very effectively through a healthcare system. Once we have got our handle on that, the public awareness and demand will rise, families will gain in awareness, and we may reach a situation where marriage counseling and being able to limit the number of new children coming up with sickle cell disease will reduce. But that should not be perhaps the front. I would certainly not begin with it, though it's tempting to begin with it. It's only in a situation where care has become available universally for people with sickle cell disease will we be able to push through with being able to prevent new cases from occurring in the future. These are my first few thoughts on that. And I think the figures that have come from both the Gujarat study and what Madhya Pradesh had to say bear me out that I think the immediate prerogative needs to be to manage sickle cell disease and manage it at the primary level as far as possible. Thank you.
Thank you, Dr. Sundaram. Moving on, Dr. Archana Mishra is Deputy Director, Maternal Health, National Health Mission. She's extremely sharp, hardworking, and gentle-hearted. She works tirelessly to improve the health of women in the state. We would now request you to share your opinion, Dr. Mishra.
Thank you, Dr. Raman, for organizing this webinar on this important day, the Sickle Cell Disease Day. And I totally go along with the views of Dr. Sundaraman. He's a well-known public health expert, and we have been knowing him since last 20 years when I joined services, and I have learned quite a lot from him. And I must also congratulate both the speakers, Dr. Graham, who has been working in this area since 1985, and Dr. Jyotish Patel, who has shared his experiences of Gujarat. And nonetheless, our partner, Dr. Raman, with the Jan Swasth Sahyog's entire team. Being a maternal health person and a gynecologist, my vision was what Dr. Raman and Dr. Sundaraman said, that it was to improve reduce maternal deaths in Madhya Pradesh. And if you look at data of NFHS, every second woman in Madhya Pradesh is anemic. And the guidelines which we have been reading was of IV supplementation, giving parenteral iron and blood transfusion. But we were fortunate to have partnership with Jan Swasth Sahyog and the I Gunatmak project, and we started working in the 6 districts where tribal population is dominant on the districts near to Chhattisgarh. And it was a great learning experience to us. And this gave us a thought that we cannot just keep on pushing IFA tablets and iron sucrose injection and think that the condition will improve. Looking at the vast tribal population in Madhya Pradesh, 20% of population of total Madhya Pradesh is tribal. So we really need to have a concrete plan for reaching this population. Like with Dr. Raman has shared that about 69,000 pregnant women were screened, and when they came out to be positive, the near husbands and near relatives were also screened, and about 17% of them were sickle cell trait, and about 1.2% were sickle cell disease. Uh, we were actually, I must thank Dr. Pallavi, who's the Principal Secretary of Tribal Health. She has been our Principal Secretary Health also, and a very passionate officer. Actually, funds were no constraint, but how to make a robust and concrete plan for reaching out to the women and the children. Because currently, if we look at VHNDs, we are just doing hemoglobin. If the hemoglobin is less, the women is being shifted to higher centers for iron supplementation. But since with the support of Janswas, we have started doing sickle cell screening in those 6 districts, but we have to reach across the state. So what is the plan of government of Madhya Pradesh under leadership of additional chief secretary Sullivan sir and our health commissioner and mission director, that we need to go in a phased manner. Of course, along with the Indian system of medicine, we'll be listening to Professor Nishant also, that first we will reach out to 0 to 18 years children and pregnant women in 89 tribal blocks, because this is the most affected population, and we assume that a number of people have this genetic disorder. So now we have one more cadre in the health system, that is community health officer. If you look at ANM, she has got a limited capacity, and training women across the state will be a challenge. So we thought that let us involve community health officer. She is posted at sub health center, and have most of them are from nursing background, or from Ayurvedic or Ayurvedic system of medicine. So we are planning to train them for screening through solubility test. Of course, we will need the support of our technical partners. And once the women turns out to be positive, a sample will be taken up to district hospital. And again, a very big achievement of Madhya Pradesh government, we have enhanced our diagnostic system through wet lease model, and we have HPLC in almost all the district hospitals. So for the confirmatory test, we will be having free of cost services in our district hospital. But this whole chain needs to be institutionalized. We cannot have an ad hoc mechanism like any other screening done for pregnant women, like hemoglobin, urine albumin, sugar, which we have been doing since ages. We need to build up a chain that if the woman comes out to be positive, her relatives needs to be screened, and then once she delivers, newborn screening will be required. And of course, parallelly, the screening of adolescent and children will go. So this is our plan of doing it, and some clinical trainings. I should not say some. The clinical competency will need to be enhanced to a great extent, not only for the field level workers, but also for the doctors who are working in hospital. And the learnings of from Janswar Sahyog and working in two districts, and also strengthening facilities at screening at our community health centers and district hospitals. We know the importance of hydroxyurea, though not used in pregnancy, but now we have a rate contract of hydroxyurea, and the use of it has gone up, and the districts have started demanding it. We have today with us our chief medical and health officers also from some of these districts who have joined with us, and we can listen to one of them, that how the things are moving, because we cannot work in verticalities, and we need to integrate this integrate and institutionalize this system, of course with the help of all the partners who are working in this area. So I am very hopeful and confident that when we observe the sickle cell day next year, we are hopeful that quite a lot would have been achieved and actually initiated in screening of women, children, and the other population. But again, as I'm going to emphasize that my focus will be on screening of pregnant women, because we have been losing pregnant women because of severe anemia, though it is an indirect cause. But in Madhya Pradesh, a lot of maternal deaths occur because of severe anemia. So I thank you again for giving me this opportunity, and we hope to work together and take the opportunity to have the uh, support of wisdom of Dr. Sundaraman, Dr. Jyotish Patel, and Dr. Graham. And of course, Dr. Raman is always with us, and we are working with him very closely, and he and his entire team has been guiding us at all levels. Thank you so much.
Thank you so much, Dr. Mishra, and thank you for your support with all the work that we do in Madhya Pradesh. We would now move on to Dr. Ruby Khan, Deputy Director, Blood Cell National Health Mission. She's driven to improve labs in the public health facilities as well as the blood banks across the state. I would now request Dr. Ruby Khan to please take over. Dr. Khan, I hope you're able to unmute your mic. Dr. Ruby Khan has perhaps disconnected. We would now move on to Dr. Rahul Bhargav. He is a clinical hematologist practicing in Fortis, Gurugram, who sees patients with sickle cell disease and thalassemia day in and day out. Besides his clinical work, which includes high-end bone marrow transplants, Dr. Bhargav is deeply interested in improving the care for patients with sickle cell disease among the poor and tribals. He will be a co-traveler in this journey with many of us. Over to you, Dr. Bhargav.
Thank you, Dr. Kataria, and thank you to the whole group. And thank you, Pallavi ma'am, for giving this opportunity. A kind of a different public health specialist. We specialize in bone marrow transplant. So I won't take much of your time. What our beliefs is, working across different places in Africa, West Indies, and in America, we feel the basic simple thing is neonatal screening is the paramount important thing, which needs to be supplemented with HPLC to give the correct diagnosis, because sickle beta thalassemia is a major problem for all of us. As we know, by solubility tests, we can actually miss the sickle beta thalassemia because they can actually behave in a very, very different manner from a phenotypic and a genotypic. Discrepancies can be there or dissociation can be there. They could be as asymptomatic like sickle cell disease to a major symptomatic like thalassemia major. And sickle cell do come with its own set of problems, just not pain crisis, chest crisis, which can be overcome by hydroxyurea, but it comes with its gamut of avascular necrosis as the patient care goes up to the next line. And transitioning from pediatric to adult care is what we need to see, along with cerebrovascular strokes and cerebrovascular accident, CVAs, along with recurrent blood transfusion. And that's the major problem, which Dr. Kataria has also highlighted in terms of establishing the blood banks, which the government of India, along with Madhya Pradesh government in the tenure of Pallavi ma'am, has done a remarkable job of strengthening the blood bank. And Ruby has done a remarkable job in training those people. Second simplest thing is hydroxyurea availability has to be there from the 9 months of age and has to be diligently followed with continuous prophylaxis for penicillin, as well as emphasizing on immunization with pneumococcal and influenza vaccines. Followed by a high end that 5% people will require bone marrow transplant. So it does not come into the prerogative of a public health, but yes, those people who failed hydroxyurea, L-glutamine, crizanlizumab, and other voxelotor and other medications which they keep on failing, they are the candidates for a bone marrow transplant. And I completely agree with Dr. Patel. If you see the pockets of Maharashtra, Nagpur, where the sickle cell is, that seems to be pretty severe, as severe as a Nigerian variant or a Congo variant. So I think we need to individualize care quite a lot, put an emphasis on neonatal screening. That's what the cornerstone is, so that all those comorbidities and the morbidity along with that can be tackled, and followed by transplant. And yes, of course, we are moving towards gene therapy. Sooner or the later, as we have just started the trials with IgIB on a CRISPR-Cas9 technology, probably it will see the light of the day and much more be cheaper and much more less morbid than bone marrow transplant. But yes, the future is holding up to us, on all of us, to provide them a better future and a better life, so they're away from morbidity. And even the Tribal Affairs Minister, Mr. Arjun Munda, has pledged to spend time to Tribal Affairs Ministry to improve the livelihood and the living conditions of these sickle cell people. So I think the ground level workers and the public health needs to spend money on neonatal screening. That's where I will put my money. And HPLC at the district level is the need of the hour, along with a 3-part or a 5-part differential CBC machine, which can actually tell, as Dr. Archana was talking about, between sickle cell, between thalassemia minor, as well as iron deficiency anemia. So these are my thoughts, and we stay committed to serve Madhya Pradesh, as we have been studied at Bhopal Gandhi Medical College, both my MBBS and MD. So I think it's a great opportunity, and I congratulate all of you and Dr. Kataria, your team, for doing a wonderful job. And sitting there and seeing the real life situation of the sickle cell is really a very challenging thing. So great, keep on doing the good work. Next year will be a better than what we are today. Thank you.
Thank you, Dr. Bhargav. We now move to Dr. Nishant Nambisan. He is Nodal Officer, Sickle Cell Anemia Screening Program for Department of Ayush, Government of Madhya Pradesh. He is the inventor of genetic inheritance pattern identification and auto-counseling card for prevention of sickle cell thalassemia. He is also the inventor of an instant palm-top remote POC diagnostic tool of sickle cell anemia with the 1/4 drop of blood and 1/4 of the cost. Over to you, Dr. Nambisan.
Thank you very much, JSS, for organizing this wonderful webinar where you have brought.
Dr. Nambisan, sorry to interrupt you, but your voice is really cracking.
Is it? Am I audible now?
Your voice is breaking, very faintly audible and breaking. Can the others hear Dr. Nambisan?
Can you hear me?
It's breaking, sir. Maybe if you can remove your earphone, then you can see if it's the problem of the earphone.
Now is it better now?
No, it's not better.
Is it better now?
Checking.
Hello.
Yeah. Dr. Nambisan, can you try? Yeah. Can you try re-logging in?
So, can you hear me now?
No, it's cracking. Your voice is cracking. It's very faintly audible.
Okay, I will try to re-log in.
Yeah. Meanwhile, we'll go on to the next panelist.
If Dr. Ruby Khan is around, we could hear her speak.
Hello.
Good evening. Hello. Am I audible?
Yes, Dr. Ruby.
Yeah. Good evening, all. And I'm happy that I'm opportunate that I'm here to share my experience with sickle cell disease in Madhya Pradesh. And I'm very thankful to all JSS team, Pallavi ma'am, Archana ma'am, who guide me to take this project forward in Madhya Pradesh. Definitely, what I found in last 2 years, like this, for the sickle cell disease, we have to go, we have to work in a convergence model. We have to think in a convergence model where we should start screening from. We should think from screening to the center of excellence from the bone marrow transplant center, like so that in MP we had, like previously it was planned that for sorry, for mass screening, but we have taken lesson from the JSS model that they had started screening from the ANC, like they have selected the maternal, all pregnant women, all children 0 to 6 years of age. So in Madhya Pradesh also, like we started, like for other district also, that we should start screening in the phase manner, where in first phase we will take, our target groups will be maternal, pregnant women and the children's, and we will start, we had started in the facility based screening, not the community based, because as previously ma'am rightly said that our NMs are already overburdened with work. So we had tried to strengthen the screening as well as the confirmation of diagnosis at district health facilities. Also, we, as in the previous presentation, like all the speakers have emphasized on for strengthening the blood transfusion services. So it is very important to strengthen the blood transfusion as well as diagnostic services in Madhya Pradesh or in any state where these programs are running for the sickle cell. So we had tried, like to strengthen the blood transfusion blood banks. We had from NHM we had appointed full-time dedicated blood bank officers for the blood bank, and we had given fund for equipments. Even we had provided blood collection transportation van to 45 district hospitals blood bank, so that they can arrange blood donation camp in the remote areas, and they can also make aware people for regarding the blood transfusion as well as the bloodborne disorders like this sickle cell or thalassemia. So we are trying a lot for strengthening of blood transfusion services as well as for strengthening of diagnostic services. Along with that, we had developed a chain of like in district hospital we had started integrated center for hemoglobinopathies, where in first phase we had started with the tribal district, where we had established a kind of daycare center for these patients, where these patients can come and can register themselves there and can take blood transfusion, as well as we asked them, we had made nodal officers, even the pediatrician we trained the pediatrician that they should follow up these patients regarding their treatment, and after that they will register those patients. Yeah, definitely we are lagging behind for registration of these patients. I want that there should be a registry system, online registry system, where we can monitor these patients from the state level, and we should have all the records of these patient real-time records that these patients are registered in this district. Right now we are not having that kind of record, but we are trying that because many organizations are working on the screening of sickle cell disease and tribal districts and many other districts. So we are taking forward with these organizations, and we had formed a technical resource group. Due to COVID, we couldn't do much, or last year we couldn't do much meetings, or we could not do. Otherwise, we had planned to develop a technical module, like training module, as well as a management module for the sickle cell and thalassemia patient, as well as the screening and the full the guideline for the sickle cell and thalassemia and other hemoglobinopathies. So I'm looking forward for the better future. As Rahul sir rightly said, we have to go with new technology as well as with a comprehensive approach from ground level to the center of excellence. So we are trying hard, and I'm congratulating to Jansa Sayog team. They are doing very good work in the periphery, and I wish we could do these kind of work in all over the state. And thank you so much.
Thank you, Dr. Khan. I request Dr. Nishan to share his views and see if that works.
Hello.
Yes.
Hello.
Yes, you.
Am I audible now?
Yes.
Okay, thank you very much for inviting me and having me on this webinar as a panelist. And I congratulate Dr. Kataria and his team that you are doing a wonderful job. And also for bringing the most eminent persons in the field of sickle cell anemia onto this stage and celebrating this sickle cell anemia and resolving to do something better than the last year so that we see a big progress next year. So I am working on sickle cell anemia since maybe 2017 now, and I have I know come across a lot of difficulties, and the most important difficulty that I was facing was the counseling of the patients of sickle cell anemia. So now, as you all know, that the sickle cell anemia cards are distributed all through India, and there are different types of cards: yellow card, white card, and these are taken to the marriage counselor, and they tell whether to marry or not. These are different cards from Odisha, Gujarat. This is from Maharashtra. This is from Chhattisgarh. This is from different states. So there is no logic behind issuing a color coded card, no guidelines, no uniformity. And the challenge was, you have to take this card to a marriage counselor, and then the marriage counselor will tell you whether or not you should marry and what are the probabilities. And the prediction of these were very challenges because you require special skills to predict the probability. And also the non-availability of the counselors discourages the prospective couples from taking the advice from the skilled person, just genetic counseling. So looking at this problem, what I did is, I made a special card, which is a patented card where you see this is the card you have. It has been, I have been very fortunate that due to the support of Dr. Ubi Khan madam, Dr. Vinita Srivastava madam for the government of India, and Dr. Archana Mishra madam, Chavi Bharadwaj madam, Pallavi madam, that they have issued these cards in 22 districts of Madhya Pradesh now. So this is the card. Actually, this is the front portion. We have 6 cards. You have normal, trait, and disease cards for males and females. This is the back of the card, and these are the cards. And how you roll out these cards is you can also use this for thalassemia as well, and also for monogenic disorders. Whatever monogenic, all sorts of monogenic disorders can be addressed through this. So how does this work? All that you have to do is, if a male and a female wants to marry, all that they have to do is they have to keep one card on the another card and flip it, and they can see the result on the back. So here you can see this is the male card, a female card is placed on it. Now here, if you flip the card, you will come to see that all the all the holes are blocked by a cross mark. Just the result will not have a cross mark, and that is the result for the couple. And here you can see, as in the example, that 50% people, the 50% of the children are going to be the diseased children, and another 15% are going to be trait. So the marriage is not advisable to such couples. So here we bring down the cost of genetic counseling, and also the myth and the difficulty of these couples going to a marriage counselor is very big, and marriage counselors are are not very easy to recruit. So you have 24/7 availability. They can do it themselves, easy access. They all the time they can have this, and this can be a very important tool for easy genetic counseling. So we have been widely covered by the media, and this is rolled out in 22 districts of Madhya Pradesh now. So the second thing, that the important difficulty that we were facing in the during the screening was, the people don't cooperate, the tribals don't cooperate. They feel that they have a myth that through the syringe we will extract their kidney and spleen and all sorts of rumors going on in the field. So we had a difficulty of drawing blood of 2 to 3 ml for HPLC. So what we did is, we tied up with the most premier institute of India, that is Indian Institute of Sciences, Bangalore, and developed a screening tool which is very cost effective. Only 5 microliters of blood is required for confirmation of sickle cell and also thalassemia. And this is a point of care instrument, a palm top instrument, and electronic device. So in 5 to 10 minutes, you get an instant report on SMS and WhatsApp. This is a very small device that you can see. This is a high performance optical sensing device which detects the HB variant. And this is also showcased on the website of Government of India as the innovation of India, a very important website where they have categorized this as a Atmanirbhar Bharat and Make in India plan. So we have quite a lot of good things to tell about this screening tool. And this is a AI based technology. And the important thing that I wanted to tell was, this can also diagnose thalassemia, because this can give you RBC, RDW, MCV, MCH, and hemoglobin measurements, and very cost effective, and a very good point of care tool. So thank you very much for having me on this webinar. I just wanted to tell you that these innovations will go a long way in bringing down the burden of sickle cell anemia and thalassemia in India. So thank you once again to the organizers of this webinar for giving me this opportunity to share my views. And I also extend my congratulations and best wishes for you for this noble work that you are doing. Thank you very much.
Thank you, Dr. Nambisan. We now move on to Dr. R.K. Mehra, a busy pediatrician who has worked in several districts in Eastern MP and has been the CMHO of Dindori district and is presently the CMHO of Umaria district. We can hear you, Dr. Mehra. Please go ahead.
Dr. Mehra, can you hear
हाँ
us?
सर, बस मैं स्टार्ट कर रहा हूँ सर, थोड़ा सा डिस्टर्ब हो गया।
जी जी
सर मेरे को देख नहीं पा रहे होंगे सर, आवाज आ रही है सर मेरी? हेलो सर।
हाँ जी, आपकी आवाज आ रही है। एंड योर
हाँ सर, मैं
फोटोग्राफ इज
देख
देयर
नहीं
ऑन
पा
द
रहा।
स्क्रीन। यस
जी सर, थोड़ा डिस्टर्बेंस के कारण सर। थैंक्स सर सभी रिस्पेक्टेड के लिए सर। हेलो सर।
यस, यू आर ऑडिबल, यू प्लीज कंटिन्यू।
सर थैंक्स, आई एम Dr. Mehra sir, currently CMHO in Umaria district. Previously I am working in Dindori. Dindori is primitive district है sir, और वेरी इंपॉर्टेंट डे है सर, वर्ल्ड सिकल डे। इस पर मुझे इनवाइट किया सर, इसके लिए बहुत बहुत थैंक्स सर। आई स्टार्टेड स्क्रीनिंग विद टेक्निकल गाइडेंस ऑफ जन सहयोग गनियारी इन डिंडोरी डिस्ट्रिक्ट सर, इन प्रिमिटिव ट्राइब्स बेगा, especially sir in Dindori. I started testing hemoglobin by electronic hemoglobinometer in district hospital, community health center, OPD and VHND sir, especially for pregnant women and children. Every anemic mother and child screen by solubility test sir. Then all positive solubility test confirmed by the electrophoresis which is provided by Jan Sayus Gunyari sir. Then confirmed by HPLC in district Dindori, sir. We provide, sir, basic care to the sickle cell patient, mother and उनकी जो monthly meeting कराते हैं सर हम लोग. We provide basic lab test, CBC, folic acid and hydroxyurea, sir. Then we are counseling for prevention of disease, awareness of disease. District having, sir, primitive tribal Bega, working on, sir, हम लोग स्पेशली ग्रुप बनाकर, जैसा जन सहयोग गनियारी ने हमारे साथ मिलकर काम किया है. हमने अभी तक सर 16,000 टेस्ट यहाँ परफॉर्म किए हैं. इसके बाद सर उनमें से जो पॉजिटिव केस हैं 400, उनका हम हर महीने फॉलो अप लेते हैं सर. सभी को इमरजेंसी नंबर दिए हैं सर, हाइड्रोक्सी यूरिया देते हैं. पेशेंट के ग्रुप हमने बनाए हैं सर, और ग्रुप बनाने के बाद में एक दूसरे के माध्यम से उनकी परेशानियों को सुनते हैं सर, उनको गाइडेंस करते हैं, उन्हें दिव्यांग सर्टिफिकेट देते हैं. कभी जब वो नहीं आ पाते तो एनएम और आशा के माध्यम से सर उनको हम घर पहुंच सेवा भी देते हैं. इस तरह से सर अभी हम प्रिमिटिव फेज से निकल के कम से कम इस स्थिति में आए हैं कि हमारा जिला सर इस काम में अच्छे से कर रहा है सर, जनसहयोग गनियारी के साथ में. और जैसा आज इस वेबिनार से हमने सीखा कि न्यूबॉर्न स्क्रीनिंग भी करना चाहिए सर, तो अति शीघ्र ही हम वेबिनार स्क्रीनिंग भी करें, ये स्टार्ट करेंगे सर, न्यूबॉर्न स्क्रीनिंग भी. और अभी मैं वर्तमान में सर उमरिया में हूं, तो मैंने यहाँ पर भी सोलबिलिटी टेस्ट के लिए लोगों को अभी काउंसलिंग की है, सभी लैब टेक्नीशियन के लिए, पैथोलॉजिस्ट के लिए, कि हमारे प्रत्येक मदर और चाइल्ड की हम स्क्रीनिंग कर सकें सर. थैंक्स सर.
Thank you, Dr. Mehra. Dr. Mehra has been very kind, and he was CMHO of Dindori when we were working in this district for the last 2.5 years. And he has been extremely helpful and always forthcoming in whatever needed to be done, was needed to be done. We also had the privilege of having Dr. Chandramohan Thakur, formerly the collector of Anuppur, and presently the collector of Sehor district. I think, unfortunately, he had to leave. So we will not be able to have his words here. And also Dr. Pankaj Shukla, Director National Health Mission, Madhya Pradesh, had joined with us. Again, he had to leave for another meeting at 7 o'clock. So both of these participants have unfortunately not been able to talk. I think we can now go on to the open house questions, if there are any. We have looked at the questions. Two of them are there, which are related to what we have just talked. How to mainstream detection. This is from Dr. Amar Naukar from Mumbai. How to mainstream detection and treatment in the public health system is Dr. Amar's question. And how do community health officers, how can they be sensitized? And will it be possible for them to keep a tab on all of these activities that need to be done? So thank you, Dr. Amar, for the question. Dr. Archana or Dr. Ruby, would you please like to take a shot at this question?
The first question was how to involve community health officers. Actually, community health officers are supposed to be a key person for delivering public health services at sub-center level, and her competency level is assumed to be above ANMs, and she has to work in the field as well as she have to provide some clinical services also. When we look at screening of sickle cell anemia, she can be made a point person for screening at sub-center level. So women can be mobilized at SHC level, because we are targeting that every pregnant woman has to have one checkup by community health officer, especially the third or the fourth checkup, that is after 24 to 26 weeks. So when she comes there, the screening can be done by community health officer. But if she turns out to be positive in screening, her sample needs to be drawn and taken for confirmatory test at district hospital, and her nearby near ones, the family members needs to be screened. But this would require a lot of training, and we have to ensure the logistics also. And again, one question related to this to Dr. Raman and Dr. Jyotish Patel, that the guidelines mention that we can go for solubility test through capillary blood, but the field experience shows that doing with capillary blood is not very conclusive, and so drawing the venous blood and doing it would be more difficult. So what should be the option? Like Dr. Nemerson was mentioning about a point of care test, whether this point of care test has been approved by ministry, and because still now we have not received any directives for it. So this is my response also, and question to other panelists also, including Dr. Raman.
Thank you, ma'am. So I have no knowledge of the HPOS test, but what I can say is that a capillary sample possibly might have some error, because the blood flow in the capillaries is sluggish, and therefore it may selectively have more sickled RBCs in patients. But I'm not sure, I'm just hypothesizing. But what I know is that when you do a solubility test, you need at least 20 microliters of blood. So that is usually not easily possible from capillary samples also, and therefore you need to take venous blood. And the advantage of doing that is that in a single prick, you can take the sample. The solubility test reports is available on that site itself. And if the solubility test is positive, you already have the sample available for doing the hemoglobin electrophoresis or HPLC. So you don't need to prick the patient a second time. In HPLC, in any case, you would need to prick the patient for the sample. So here you take just the venous blood sample once, and you will be able to do both the tests. Thank you. Yeah, and the second question that I have here on the screen with us is about from Dr. Himanshu, who's an orthopedic surgeon in Delhi. His question is regarding hip joint salvage in avascular necrosis secondary to sickle cell disease. He wants that any one of the speakers here could share their experiences. So I have very little experience of it here, because we haven't done it in any of our patients. Most of our patients are very poor, and also they are very young. Most patients with AVN that we have seen are in their late teens or early 20s, and therefore it's not easy to convince them. Neither are we convinced ourselves that at such a young age we should go ahead with the some salvage procedure in them. So I would request some of the other experts here who have joined us, whether they have any experience of dealing with AVN and secondary to SCD. Dr. Sargent, Dr. Jyotish Patel, or any of the others.
Sir, if you permit me, like we do not have currently data of the surgeries being performed for sickle cell disease patient. Maybe in medical colleges, like the patients might be going to Bilaspur Medical College or Jabalpur Medical College. So this is a good question, and we really need to look at it, whether such types of surgeries are happening or not. As of now, we do not have any information, sir. So we need to coordinate with medical colleges and have the information regarding continuum of care and which procedure was performed, which surgeries were performed, and when any other higher end intervention was done at medical college level.
Thank you, ma'am. Now, actually, we have already far exceeded our time. And I would request you, Dr. Archana, ma'am, to kindly say the concluding remarks and vote of thanks.
So there was
Dr.
another
Archana,
question
please.
in the chat box, sir. So if you can just it was regarding
Yes.
pain management, sir. So if you can just talk about it for a minute, sir. So we are curious to
So,
know about pain
yeah.
management in sickle cells.
Okay. So actually, this was not meant to be a clinical webinar. It was meant more to be a public health, what should be the public health response to such a disease, and which is why I deliberately avoided, because we would then end up doing a whole different level of discussion. And I think
Okay,
at the
sir.
end of this day, we would try to, yeah, Dr. Archana, please.
Thank you, Dr. Raman. And on behalf of Jan Swasth Sahyog and National Health Mission, I thank Dr. Graham Sargent for joining with us and illuminating us with such a nice talk on the experiences of sickle cell disease, the work which he has done since last 3 decades, and how things have emerged, and now he has shown us the path how to move forward. And actually he has sensitized us more on the gravity of the issue, which we really need to look at government level. And Dr. Jyotish Patel, who shared the experience of Gujarat, working at really at ground level and coordinating with medical colleges and secondary level institution, how the continuum of care has been established in the study which he has shared with us. Of course, Dr. Pallavi Jain, who was our commissioner and principal secretary, and who has guided us to have focused approach on addressing this issue, which is very pertinent when we look at the plight of the tribal population, which Dr. Raman has shared, that the problem is more with poor community who are coming to our government institution. The other esteemed panelists who joined with us, Dr. Sundaraman, all of us know, and we are fortunate to hear his wise words and his thoughts on how to go ahead in this area. Dr. Ruby Khan, Deputy Director, Blood Cell, who has been instrumental and in ensuring the logistics which are required for screening, management, and follow-up of the hemoglobinopathy patients. Dr. Rahul Bhargav, being a student of Madhya Pradesh, he has been always kind enough to join in any meetings and webinars and help us in giving clinical and technical guidance in any area related to hematology. Dr. Nishant, professor of homeopathy, we'll be working closely with him in this area. Now our focus has been limited as of now to only 5-6 districts, but we have an ambitious target of reaching to all 89 tribal blocks in a comprehensive manner. I thank him for joining this workshop, and Dr. R.K. Mehra, who has been one of our very, I should say, proactive chief medical and health officer working in remote area, and his leadership has shown the number of screening being done, the disability certificate initiative which was taken. It happened along with the support of Jan Swasth Sahyog team also. And so let us conclude. And again, I would like to thank Dr. Raman, Pankaj, Rahul, and I may have missed few names also, but all the participants also who joined with us, and they asked some important question, and we were enriched with the knowledge in this webinar organized by Jan Swasthya Sahayog. Thank you, sir.
Thank you very much, ma'am. Dr. Sundaraman, if you would like to say some final words of advice.
So thank you. I was happy to listen in on sickle cell after a long time. अभी इतना COVID चल रहा है कि we hear nothing else. So when you offered on sickle cell, I thought let me come back, and this is an area I've been interested on. I'm happy also to note that neonatal screening now, which was a very uphill task to even introduce, has a certain acceptance now as a major stream, and also hydroxyurea at the primary care level. I keep saying that we'll need training, we'll need support, but we will need that. The one point I want to say, look, in COVID-19, we've been doing so much rapid innovation in diagnostics and rapid innovation in vaccines, etc. It's high time we developed more point-of-care diagnostics. There isn't a point-of-care diagnostics for neonatal screening, but it isn't beyond the possibility to develop one. So there is a need to for further innovation to get more appropriate tools. And like you have made electrophoresis cheaper, which I noted in your presentation. It makes it relatively more point-of-care. But we should be able to bring together the requirements of the tools required for innovation to meet sickle cell within our thing. We should also ask for categorizing sickle cell, if it's not already done, as a neglected tropical disease. It's not really tropical. I was seeing that thing, but the point about it is that it would help spur innovations that you also require to extend the care. Otherwise, much of the advice we give is most appropriate to a medical college or district hospital setting. And yet, sickle cell affects some of our poorest populations, which are most widespread out. So I think there is a scope to think of that. That's perhaps not the district mandate, not your mandate, but at some level we need to advocate and move for that. Thank you.
Sir, I would also like to thank Dr. Pankaj Shukla and Dr. Chandramouli for joining the webinar, though we could not hear both of them, but they joined the webinar, and also one important person, our assistant program manager Prachi, who has been working in with me and coordinating with Rahul and Pankaj and the JSS team in taking the things forward. So, thanks to her also.
Thank you very much, ma'am. So you can see Rahul here, who has led the sickle cell program in Madhya Pradesh, and I think it's basically his hard work and drive which has brought about whatever was possible in Madhya Pradesh. Rahul, many of you may not know, is not a doctor, but he is a computer engineer. And from computer engineering, he decided that he wanted to do public health, and this is the area which he chose. And now he has been able to make a major contribution in this work, and I congratulate him for his work. Thank you very much. Thank you.
Thank you, sir.
So we'll take leave, and thank you so much, all of you, for joining and for your precious time on a Saturday evening. Thanks a lot.
Thank you.
Thank you.
Okay, keep in touch, all of you. Thank you. Bye.
पंकज जी कुछ बोला जा रहा है?
हेलो राहुल जी, हेलो राहुल जी, राहुल जी, पंकज जी,
नमस्ते शिवेन जी. Just 1 second.
आज सर ये जो वेबिनार रहा ये बहुत ही इम्पोर्टेंट था. थैंक यू इसको मौका दिया हम लोगों को सीखने का. थैंक यू सो मच.
थैंक यू. आपने समय निकाला इसको अटेंड करने के लिए. थैंक यू डॉक्टर शिवेन.
सर थैंक यू सर.
Thank you, Pankaj, Rahul.
Thank you, ma'am.
Thank you. It was excellent effort. And now we have to finalize our guidelines actually. We need to publish it now. So,
yes.
Start with the training again. So let us move on with the speech till we are free of COVID.
Yes.
Thank you. Bye bye.
Thank you. Thank you, ma'am. Thank you.
Bye bye.
पंकज आवाज आ रही है? हाँ आ रही है.
आवाज आ रही है? अच्छा जी ठीक है. You were trying to say something. Sorry. आप कुछ बोलने का कह रहे थे, हमारी आवाज चली गई थी.
अच्छा सर. मैम बस वही कह रही थी कि we should finalize the technical guidelines as soon as possible.
Yep. Okay. ठीक है. So most people are leaving. ठीक है पंकज.
Okay sir.
All
Thank
the
you sir.
best. Bye bye. Bye. Take care.